we don't want women like pulling out their hair and banging their head on the wall thinking I'm exercising, I'm eating right, but I
It,
can't seem to get control of my life again.
yeah. And that is the frequent thing I hear is just like, I feel like this is not my body anymore. I don't feel like myself.
I'm so happy to have you on, Kristin.
Thank
This is
you.
Dr. Kristin DeHaven, who's an
I,
OBGYN and who's been practicing in Winchester as long as I've been here,
yeah, like 2003.
2003. So yeah,
Yeah.
so about the same time.
Yeah.
Um, Initially started doing OBGYN and then transitioned to purely GYN.
Yes. It was
Um,
a much needed transition for me.
much,
Delivering babies
yeah,
is stressful and yeah. So
and
it was,
it's a 24/7 thing.
yeah. I ran a red light being post-call one day, and it was like a come to Jesus moment. I was like,
Yeah.
I can't I don't function well after being on call.
Yes.
So it was a good move.
Yeah.
I enjoyed it while I did, but I think I'm a much better gynecologist than I was obstetrician. That's for sure.
Okay.
Yeah.
Okay. And
Right.
so you've been doing purely gynecology now, Kristin, for how many years?
Since summer of 2017.
Okay.
Yeah.
So yeah, so at least
Yeah, like 9
almost
years.
10 years. Yeah.
Yeah.
Yeah, that's
Oh my
wild.
gosh.
And then I also think of you because both of us um, got to do that medical mission trip to Haiti together.
Yeah.
And that was my first time, and that was your second time at least.
I think so, yeah. Yeah. I did a
Okay.
bunch Shenandoah University, the PA students usually go to
Yeah.
Nicaragua, and I had done
Yes.
probably like 3 or 4 trips with them. But
Okay.
ultimately, Dr. Dabinet, I don't know if Dr. Dabinet got you if that's how you got
Yes,
into it.
that's how I got
Yeah.
into it. Yeah. To Haiti.
She was a powerhouse. She is a powerhouse.
Yeah.
So we did like 5 trips, and
Okay.
then I've
That's
done
amazing.
some work in, India as well. So
Yes, in Tamil Nadu, right?
yes, yes.
Yeah.
Yeah. So, anyway, I have not done a mission trip in so long, but I'm hoping to get back in with SU and go back to Nicaragua next year. So, fingers crossed.
Maybe I'll try to get on that trip too.
Oh my gosh, please
I
do.
was I was signed up to go to Nicaragua, and it was the year that there was some political upheaval, and they
Right.
canceled the trip.
Yeah.
Um, oh, okay. I would love to do that, so I might get
Oh, that'd
back.
be
And then I
super.
think I was almost signed up this year, but they said that they had closed some of the visa applications, and so they couldn't
Oh,
take any more
okay.
people. But
Yeah.
um,
Well, that would be so much
so
fun though.
that would be amazing. That'd be
Yeah, it would be.
amazing. So I've known you through patients. I've known you through the the medical mission trip together, and I also know you because you're my gynecologist. So on multiple levels, I now I have worked with you. Thank you.
You're
Um,
welcome.
so can you tell me, since we're talking about perimenopause and menopause,
Yeah.
and I want to get a gynecologist perspective on this, can you tell me before you embark on prescription medications, are there lifestyle or um, natural remedies that you suggest to patients,
Sure.
suggest to women?
So, um, first of all, I'm a certified menopause provider through the Menopause Society, formerly called the Menopause Society of North America. But anyway, so I try really hard to stay up on top of the most recent things. And there are so many things that have been studied, but not a lot actually work out short of pharmacotherapy, medications. Cognitive behavioral therapy does help.
Yes,
And I believe all of us need therapy.
I agree. I agree.
Yeah. And so, I think CBT, we know it's helpful. Um, Unfortunately, things like acupuncture, even exercise, like we used to think, oh, people would exercise, that it would decrease the overall number of hot flashes. And I told patients that for years, but some studies have shown it really doesn't.
Yes.
So cognitive behavioral therapy. Um, and I still, in my heart, believe that nutrition is just so critically important and exercise. So I try to tell my patients, I just think that if you're healthier, at least your physical body will be better able, I think, to handle the hot
The
flashes.
changes.
Yeah.
Yeah, I
So,
agree.
yeah.
I agree. Just that's kind of an intuitive thing, but at the same time, we don't want women like pulling out their hair and banging their head on the wall,
No.
thinking I'm exercising, I'm eating right, but I
It,
can't seem to get control of my life again.
yeah. And that is the frequent thing I hear is just like I feel like this is not my body anymore. I don't feel like myself. Um,
Okay.
I think one of the biggest things that I just wanted to throw this out there is the general distrust that I don't know where this comes from. And I'm sure you've seen this in your practice, but so many folks are getting their hormone therapy online, or they're getting it from folks that aren't traditionally trained like you and I are, and I don't have a problem with other people prescribing hormone therapy. What I do get beef with is the
Yes.
complications that can happen from hormone therapy. And then these folks are like, "Oh, I can't fix that. Go find a gynecologist." And I just wish,
Yeah.
I wish that the trust was better. And I understand where things get fractured in the healthcare system, trust me.
Yeah.
But yeah.
So kind of brings me to one of my questions, which is how the medical perspective on hormone therapy has shifted. Because when you talk about the online patients finding online practitioners,
Yeah.
I was talking to a friend of mine, a childhood friend who's my age, so late 50s, and she lives in Florida. And she
Yeah.
said she was talking to an online provider about hormone therapy. And I said, well, why are you doing that? Don't you have a primary care doctor or a gynecologist? And she
Yeah.
goes, I have both. And then I said, well, they must be men. And sorry. And
That's okay.
she said, no, they're both women. So then I was shocked. So she has a me and a you, but they were not going to provide prescribed hormone therapy for her. And now this was a year ago. So
Yeah.
so she was
That's
driven to somebody online. So can you take me through some of the
yeah.
waves that you've seen of how medical providers have
Yeah.
prescribed, then stopped prescribing, then restarted prescribing?
Well, I'm gonna say this very clearly, shame on them.
Okay.
So the Women's Health Initiative came out, I want to say 2002 or 2003. I was working the day that like Katie Couric and Oprah told the world about the study. And, we got a bajillion phone calls. Women completely panicked because the news, as reported, was that hormone therapy caused breast cancer, right? And they were talking in terms of absolute risk. And that's hard for people. That's not tangible. Even for me, sometimes it's so much
Yes.
helpful to look at, well, what's the absolute, like, how many people per 10,000 are going to do this? So at that point, that was again the early aughts. And a lot of people just stopped their hormone therapy cold turkey. But I'm going to tell you that I feel like it didn't take long for us to understand the Women's Health Initiative study was inherently flawed. So what they had wanted to do, and this is for your audience because I know you know this,
Mhm.
it was a randomized control trial, and they wanted to make sure that the patients didn't know whether or not they were getting placebo or the active arm. And of course, if you're in the throes of having horrible hot flashes and night sweats, and somebody hands you a pill and they go away, you're going to be like, "Hey, I'm the lucky one. I got the good stuff." So they picked a patient population that was older that really didn't have hot flashes and night sweats as the big thing. And so because they didn't want bias to be in the study. And I appreciate that. But again, we figured out early on that it wasn't the ideal population to be giving hormone therapy, right?
Mhm.
I think the average age was like over 60. Don't
Yes.
quote me
Yeah.
because I
Yeah.
haven't looked at that study in forever, but it was an older population.
Mhm.
And again, my recollection, which is now over 20 years ago, was that I remember going to a conference maybe the next year and people already talking about, hey, you have to be careful because it's the wrong people And the breast cancer risk really doesn't start to increase in theory until after 5 years of use. So I feel like those of us who were educated n- didn't have a long period of time where we stopped prescribing it.
Okay. Okay.
And that's the part that really irritates me, is because I think that those folks that didn't bother to continue their education or whatever,
Got
or
afraid.
practice from such a fear mongering viewpoint, like they're going to get sued.
Yes.
You're going to get sued regardless. Like, do the
Yeah.
right thing.
Yeah.
Anyway, so
Thank you.
I know that some people never rebounded from that.
Yes.
Yeah,
That makes sense. That
but
makes
we
sense.
have known for a long time that I've been telling patients this for at least a decade, that HRT is safe. It's the right person at the right point in their life. And previously, I would say for the right period of time. But even just last year, a study came out showing safety data through the age of 65. Now, yes, there are definite changes in breast cancer risk with certain types of hormone therapy, but knowing now that it's safe to use in carefully selected women through the age of 65, like, that's huge.
And so, you kind of take an individual approach. How do you weigh the risks and balances of hormone therapy? Yeah, can you just tell me when you're approaching a
Yeah,
patient
you know,
who's
it's
menopausal?
it's pretty safe for the vast majority of people. There are gonna be those strict contraindications, right? Somebody's had a blood clot in the deep veins of the legs or a blood clot in the lungs. And as you know, pregnancy is the number one time in our life where we are at the most risk of having a blood clotting event. So if patients have passed through pregnancies without any of that, or if they've taken birth control pills in the past without any significant complications, oh, for me, that's always a good litmus test of who's going to do well, without significant complications. You can't take it if you've had a heart attack in theory. You can't take it if you've had a stroke, especially if it's like an ischemic stroke. And there are, of course, relative contraindications, like, certain types of liver tumors are fed by estrogen. Um, oh, I get nervous if people have really wicked hypertension that's not under good control, or wicked diabetes if it's not under good control. But if we're working with somebody like you, then a lot of times we can make these things work if we get, you know, things under
Just
control.
monitoring
Yeah.
monitoring them carefully. Yeah.
Yeah. And
So
so,
so so even with women with heart disease, um, depending on how many years they are from their heart disease and involving their cardiologists, we can still
Mhm.
make it work. So individually, we just approach everybody and look at what their symptoms are,
Yes,
what their history is, and what
exactly.
solutions we can come up with.
I also think it's important for women to have a why. Like, why do they want to be on it? Um, I think that ideally there should be something that we're looking to correct or improve. I get nervous when patients are like, "Well, I just heard it was good for me." And I'm like, "Yeah,
Mhm.
you really should,
Every
there should be a reason."
everything, yes.
Yeah,
So
and then
everything that we prescribe has some benefit and some risk. So women
correct.
have to understand that just because it's working well for somebody, if you're not having symptoms, it may not
Yeah,
have any benefit for you.
right.
So, um, what are some of the symptoms that women come into you complaining about that make you initiate hormone therapy?
Hot flashes and night sweats, what we call vasomotor symptoms. Folks are like, "Hey," I mean, I've heard, you do this for 30 years, you've heard everything, right? I
Yeah.
remember a physical therapist that told me she would get hot flashes and sweat on her patients.
Yes.
Not ideal. We get patients that are, leading board meetings, and they're like, "I
Yes.
turned beet red," or teachers, right? They
Yes.
can't leave the
Yeah.
classroom, you know?
Yeah. Yeah.
Um, so those types of things, folks that can't sleep at night, I mean,
Yeah.
again, you preach this probably every day. You cannot underestimate the power of restorative sleep. And
Yeah.
so fractured sleep is huge. Um, Other things I hear, and not everything needs systemic hormone therapy, right? If someone has vaginal dryness and pain with intimacy due to that, I can fix that with vaginal estrogen, um, which is even safer. There's data out now showing that breast cancer survivors can use estrogen vaginally. So we have a lot that we can offer these folks that we didn't even have previously. And then maybe someone doesn't have a lot of hot flashes or night sweats, but they're in the right age group, right? They're, 50, 51, and they're saying, hey, my mood is all over the place.
Yeah.
Of course, we're going to talk about stressors in our lives, right? We're going to talk about, we're going to work on this, but also this is that time in our life where a lot of suppressed emotion starts to come out. There's only so much you can shove down. And I feel like this,
Over years and years.
yes, the garbage can is full. And I think that our late 40s and early 50s are a time that synchronizes with that further inability to continue to shove stuff down and function. So again, that's why I love therapy. But hormone therapy can, for some people with, mood issues, can be super helpful. So,
Yeah.
and as long as they're healthy, I tell every patient this, I'll take credit for everything I can fix. Okay. If I give you hormone therapy and I fix your joint issues,
Yeah.
your
That's great.
hair, you feel like you're not losing hair as much, you feel like your skin is better, your mood is better. I'm gonna take credit for that. But after like 6 months of use, if there are things that are residual, then we need to take a step back and say, okay, maybe that's not hormonal. So that's always been, again, kind of my litmus test for patients is giving hormone therapy. And as long as they're healthy, I just don't really have a problem with trying.
That's perfect. And what about um when a woman is perimenopausal and starting
Mhm.
to have these symptoms, how do you treat them, and
Yeah.
what kind of options do they have?
So it depends on how old they are.
Mhm.
We're very specific on how as certified menopause providers on how we define perimenopause. And for us, the primary diagnosis is based on changes in the timing of your period, not necessarily the flow or the amount, but timing. And generally in early perimenopause, the cycles start getting closer together. So for me, that is an important thing for me to know, whether or not somebody still needs contraception. Um, and so if I have someone that's, you know, cycles are getting closer together and they're talking about hot flashes and night sweats, sometimes we do birth control pills without a placebo interval.
Okay.
So
So
that
just
we
continuous low dose birth control
Mhm.
until approximately they're at an average age for menopause?
Yeah, or sometimes what we'll do, a lot of times patients will like, "Can you just tell me if I have to worry about birth control anymore?" So we'll have them come off their hormone therapy just for a brief period of time and then check hormone levels, specifically follicle stimulating hormone that comes out of the pituitary here. Because if the ovaries aren't responding, that hormone FSH will be wildly elevated, and that can be super
Okay.
helpful. But yeah, well, no, if I have somebody that's on birth control pills and they're healthy, I'm not gonna take them off of it to figure out their contraceptive status till 50, 51.
Talking about low dose birth control pills, sometimes it gets uh, sometimes I hear a lot of uh, negative discussions about birth control pills, and it's
Yeah.
fascinating to me because um, this is a medicine that one prevents pregnancy, and we know that during pregnancy, your risk of blood clotting is much higher, risk
Yeah.
of all kinds of health complications are much higher.
Right.
So that is a huge plus of birth control pills. And then secondly, they reduce the risk of ovarian cancer.
Yes, with
So
5 years of continuous use.
so you're having a cancer preventive medication as well.
Yeah.
Um, can you tell me other benefits that you find with low dose birth control pills and people that you're selecting it out for?
Sure. So if I have somebody that's struggling with heavy or irregular bleeding that's driving them nuts, we're going to look for an anatomic cause. Of course, ultrasound is super helpful looking for fibroids and polyps. But birth control pills can help stabilize bleeding patterns, especially if they're heavy and irregular. So if I have someone that need is starting to have some symptoms and their cycles are just all over the place, birth control pills are a wonderful option to gain control over that again. Um,
Thank you.
the other little magic trick we have in our book, in our little magic bag, is
Yes.
the progesterone releasing intrauterine device. And that's another thing that has always made me scratch my head, like, why is there such uh, bad information out there? You look in Europe and it's like, I think, again, don't quote me, but I feel like it's like close to the number one contraceptive used in Europe.
Yes.
But in
Yes.
the United States, there's such stigma about it.
Yeah.
Um, but it's a great it's a great thing. It decreases, or it can have a positive impact on fibroids, like preventing them from getting bigger. Not an FDA approved use, that's off label. Um, but it is two of them are FDA approved to fight heavy menstrual bleeding.
Yeah.
And that can also simplify hormone therapy.
Yes. And then it helps during that transition into menopause.
hmm
Yeah.
Yeah, no, it won't do anything systemically. But again, perimenopause can be a time where, nobody wants to have a period every 21 days or have bleeding that's unpredictable. And so if we use, so you know that if you have a uterus and you're taking estrogen, you need something to balance the estrogen's impact on the lining of the uterus, just like our ovaries did. And so if we're using an IUD that's secreting a progesterone-like hormone, then that's balancing the estrogen. And then, 80% reduction in bleeding with the two FDA approved IUDs that can help heavy menstrual bleeding. Um, so it is a fascinating topic, and so
So
I use IUDs a lot.
clarify for me then, Kristen, you're saying that you would use so say a woman who is in her 40s has an IUD
Yeah.
and she's becoming menopausal,
hmm
but it would be hard to detect that, correct? Because you couldn't necessarily do blood
No,
work, or would the FSH still be elevated in a woman
no.
that's no.
Yeah, no, you can still check their labs,
And
because the IUD really works focally for the most part within
okay,
the
so you wouldn't see like a
a
suppression of the
pulse.
FSH with the
No, no,
IUD. Got you,
no.
got you. So
Yeah.
so then you'll check an FSH, and if they are menopausal,
Yes.
is that when you would add the estrogen? Or if you have or I guess perimenopausally, if you have a woman who you need the IUD because she is potentially at risk of getting pregnant, then
Yeah.
you add the estrogen for the vasomotor symptoms
Yes.
or vaginal dry or other symptoms that could
Yeah.
be estrogen linked.
And then
Perfect.
you've got your, the hormone that it's levonorgestrel, but it's progesterone-like, to prevent the
Balance the
estrogen
est
from, yeah, so you're balancing it just like your ovaries did. It's a great,
and
great.
a great combination. And so,
Mhm.
um, describe to me though, in a woman who is using estrogen and progesterone, uh, not via the IUD or by birth control pill, so
Yeah.
that's gone through menopause, and we are now deciding to initiate hormone therapy in them.
Okay.
Do you always look at the topical estrogen as the optimal way to deliver estrogen?
I do. I do, because the studies are really pretty clear that, yes, there's still risk, but it's less than taking estrogen orally in regard to, obviously the most severe side effects like like blood clots, heart attack, stroke. But it's kinder to cholesterol and triglycerides because it's avoiding metabolism in the liver the first time around. Um, Cleverly called first pass
Yeah.
metabolism. So,
Yes.
these days, because hormone therapy is blossoming, because people are using it more, the patches are harder to come by. So I've
Yeah.
more recently been using the transdermal gel packets. You
Okay.
apply the gel and clean skin once a day,
Okay. And
estradiol.
so, you're
So
finding that equally efficacious for women that are transitioning from the patch to the gel.
yes, yes.
Perfect.
Yeah, I mean,
And
it's not as
even
convenient, but
but not as convenient. And so even if they're using topical estrogen, the
Mhm.
recommendation is still that they be on oral progesterone.
Yes, and progesterone just doesn't seem to have the negative side effects as estrogen does. Kinda like with birth control pills, right? If somebody has a contraindication to estrogen-containing birth control pill, you could use a progesterone-like,
Oh,
birth control pill right? Um,
yeah.
so, yeah, so the progesterone orally is not a big deal. Now there are patches that have both estradiol and a progestogen in them, but they tend to be kind of bulky and they're still trademarked. Like they're still on their patent. So they tend to be a
So
little
they're
bit more
expensive.
expensive as well. The
Okay.
other thing that's really interesting is that when you take micronized progesterone,
Mhm.
which is what we might call biosimilar, it's the same compound as what our ovaries made, um, it makes you sleepy. So that can be huge for patients who, need more help with their sleep.
Mhm. And so you find that the estrogen helps with the vasomotor symptoms, the hot flashes, the sweats,
Mhm.
um, maybe some of the mood lability, maybe some of the mental fog,
Yeah. Mhm.
possibly some of the vaginal dryness,
Yeah. So,
and
yeah.
uh-huh,
So if we have
and the progesterone helps a lot with our sleep, and of course preventing buildup of the endometrial uterine lining.
from that, yeah. So, estrogen, if you have a uterus, the key is estrogen has to be balanced by something. Either it's in your patch or you're taking it orally or you have an IUD that has enough of the levonorgestrel, progesterone like hormone to keep the uterus from bleeding because otherwise,
Okay.
yeah. And some people will say to me, "Well, hey, Dr. DeHaven, like, how do you know if I'm getting enough?"
Yeah.
Like, and that's the other thing that kinda irritates me with again, with some of the online, I'm glad it's meeting people's needs, but they make these people feel like they have to get labs. And again, when we're trained to be more holistic. I don't need fancy blood work. If you tell me your hot flashes are gone, we're doing great, okay? And if when we're talking about the ratio of estrogen to progesterone, then if you're having bleeding, then I know I need to up one or decrease the other. I don't need lab work to tell me that. And so I think sometimes that's been ingrained in social media. And
Yeah.
so a lot of people feel, but I'm like, you don't have to have blood work done. You can just tell me if it's working and I believe you. And what's a
So I
number going
had
to do anyway?
Yes, so I had a 36-year-old woman, roughly, no, I'm sorry, in her 30s, in case she watches this, in her 30s, who said that she had read about doing hormone levels every 6 months. And I was trying to understand, like, so what am I going to do with that information? Like, your hormones are
Yeah.
fluctuating throughout the month all the time. So
Yeah.
it's a very interesting idea that we should be monitoring your blood work,
It's not real.
hormone levels every
Y
6 months.
and you have to and me getting suspicious is if,
Mhm.
if she's working, is somebody making money off those labs?
Yeah. Yeah.
I get suspicious, but again, that's the hard part about checking hormone levels, right? So we try to really reserve it for women who are having demonstrable symptoms, maybe or if they're in a weird age group and their periods or they're losing their periods, they haven't had one in 60, 90 days and that's repetitive, then of course we'll check things. But
Okay.
sex hormones aren't the only things we would check, right? We check thyroid function, look for
Yes.
other secondary causes.
Causes.
Yeah. In younger age population.
So I love the hormone story in women's lives. So can you talk just briefly outlining from when we start our cycle
Mhm.
to after menopause, what are the hormones that are shifting and
Sure.
how do they shift? Just like a quick outline.
Yeah.
So,
I don't know how quick it'll be, but
okay.
again, the menstrual cycles in somebody without any other reason to have irregular periods, right? And this is the
Yes.
hard truth is that weight struggles, whether you have a body mass index under 18 or a body mass index over 30, those two things can impact the timing of cycles,
Yes.
thyroid dysfunction. So again, I'm talking about just average Jane Doe without any issues, okay?
Yes. Okay.
um, we're really listening to the timing of her cycles. So if she's, 48 and her cycles had been regular,
Mhm.
28 days apart, and now they're 26, and then they're 24, and then they're getting close to that 21 mark,
Mhm.
then we know she's probably in early perimenopause. And that's the time around which, sadly, our ovaries don't have as many eggs, right? And the eggs are not as of good quality. And so what we see is that the pituitary gland, who's in charge, well, the hypothalamus and then the pituitary, for being picky, they're in charge of the ovaries. And so, those ovaries feed back information to the brain. So if the deep centers of the brain are like, I'm not getting estrogen back, what's going on? They just start screaming at the ovaries. And that's that follicle stimulating hormone. And so if we were to check labs, generally speaking, FSH will be elevated during perimenopause because the brain's trying to make the ovaries work. The ovaries are like, I don't have much to give. And so later in the transition, really about the time where periods have been for women like 21 days apart, then they'll start dropping out cycles. And it's in that time frame where they're not menstruating for 45, 60, 90 days that the hot flashes seem to be the most intense. They're still potentially fertile, right? They haven't exhausted everything. Being menopausal is a diagnosis in retrospect, right? It's the right timing for someone, no other secondary causes, and no period for 12 months.
What I love to acknowledge about what women's journeys are and how they differ from men's journeys is that from the time that we start our cycle, we are kind of dealing with this hormone fluctuation.
Every month.
Estrogen, progesterone going up, you get pregnant, it stays up, you don't get pregnant, it comes down, it sheds. That drop in the hormones is like the signal to the brain, I'm not pregnant, shed everything, shed the
Yeah.
lining out as my period. And you go through this cycle through your life and you struggle with all the premenstrual symptoms. And then you get to your 40s and you think, oh, I'm going to start going through menopause. This is going to start fading away and then end. But instead, it becomes crazier,
It can
and
be. Yeah, with the
and your
timing.
symptom, yeah, and your
Yeah.
symptoms start to just stack up, and then you stop having periods eventually,
Mhm.
and then you go through a whole nother slew of symptoms. So it's like this, and meanwhile, your body is going through all this while you are still having to raise
Work.
children,
Yes.
work, be a wife, be a productive member of society, but your body is doing all of these things that you have very little control over. So
Yeah.
so I always admire women in a sense because we are coping with these things and smiling and going about our day-to-day
Yeah.
um needs,
I think
which
we're
I think
really
is amazing.
yeah, I think we're very resilient.
We are
Um,
resilient. Yes.
but I also think, there's such stigma about breaking down or you're breaking down, right? Like having
Yes.
an
Just
emotional
even the
time.
words that we use. Yeah. Yeah.
Yes, they're so
Yeah.
um
Yeah.
and I yearn for a time where I think there's equality in how we discuss these things and that
Yeah.
there's a lack of stigma with wanting to talk to a therapist or,
Mhm.
being more comfortable talking about these things with our families and
Mhm.
yeah. I mean,
Or
we
just
are resilient.
acknowledging. Yeah, we are resilient and just acknowledging how hard it is. You don't know how many times I'll see women who will say, um, I don't have any reason to feel bad. I don't have any reason to complain. And I'm like, just, it's
Yeah, you
okay.
probably do.
You probably do. It's okay. You can feel overwhelmed
Yeah.
and you have permission to cry. You have permission to
Yeah.
say, it's difficult journey sometimes. So even if we have a lot to be thankful for. So,
Absolutely. Yeah. And
thank you
it's
for that. And I
yeah.
did want to ask you, for symptoms of hair loss, sexual dysfunction, and urinary incontinence,
Yeah.
what are some? I know you do a lot of creative treatments. What are some treatments that you offer beyond hormone therapy that could help women individually in
Yeah.
these areas?
Well, I will touch on vaginal estrogen again because it has been shown to help with urgency of urination, but not
Okay.
stress incontinence, not like the loss of urine with cough and sneeze. But obviously, if your vagina has lost its elasticity, it's dry, the labia shrink, the opening can narrow. So I do really believe in using estrogen to optimize the vaginal environment. And I think we need lots more people in the community that do pelvic floor physical therapy.
Okay.
because once you get that vicious cycle of sex hurts, those muscles can become overly tight, and then it's just this horrible feedback loop.
Yeah. And then
Um,
your brain says, I don't want sex.
and so
And you
libido,
think it's, yeah. And your
yeah,
libido drops. Yeah. Okay.
okay. So for
So
libido, yeah,
vaginal estrogen and pelvic floor exercises to help with incon
yeah,
some of the incontinence symptoms.
yeah.
Okay.
And we now I don't have any financial relationship with these companies, but there's a company that has a device called Leva, and it's at-home physical therapy. It's a real flexible, slides into the vagina, and it has pressure sensors,
Uh-huh.
and it pairs with a smartphone, and there's nursing assistance as well. So it's great for folks that just don't have the time to go into physical therapy.
Uh-huh.
I don't feel like it replaces physical therapy with the right person, but I think for busy people, it can be a big help for stress incontinence, um, in painful intimacy. If we
Okay.
especially if we find trigger points in the pelvis, when we do a pelvic exam, if somebody says sex hurts, I'm actually gonna palpate that hammock of muscles in the vagina
Mhm.
just to look for trigger points because you can
Okay.
absolutely have them.
Okay. And can this device target those trigger points?
So trigger points, generally speaking, are gonna need more help than that.
Than that. Okay.
Yeah, but
Okay.
I mean, I've had patients that have started physical therapy and their therapist has, shown them on Amazon the little wands that you can use that they're kind of like an S curve and you can get in there and massage the
The area.
levator complex and try and work out
Okay.
those but
Yeah.
control
Kind
deep
of like
breathing.
working out knots elsewhere in your body.
Yeah,
You have a massage.
yeah.
Okay.
But like controlled deep breathing anyway, there's a lot of stuff and that's why those experts have gotten their doctorates and they're very smart and we love them.
You're proud of
Um,
that. Okay.
okay, libido. So I always joke that libido is a big stinky onion. It has a lot of layers and nobody wants to talk about it or be around it.
Okay.
So, in my practice, I try to offer a 30-minute sexual health consultation
Uh-huh.
because there's too much to talk about just oh, by the way, it's your well woman exam. Like, I truly
Yes.
think this deserves time because it's a lot of people kind of think it's hormonal, but the science has shown that testosterone levels change independently of the hormone transition. And so my hormone therapy, if we're it's just there's more to it. So we do talk about interpersonal relationships, connectivity. How often are you getting out of your house? Like going on dates, getting away. So we talk about all that stuff. But then there's also room for testosterone therapy. Um, Testosterone has been shown to help women with hypoactive sexual desire disorder, which, if you kind of like boil it down, is essentially really bad low libido. um, but it's not a miracle worker either. It has been shown to increase sexual encounters maybe by 2 or 3 a month.
Okay.
But for some people, that can be a huge improvement because the lack of sexual connectivity can so negatively impact the relationship. I don't think I again, there are many things I say repetition with repetition, but I truly feel like if the world were burning down, meteors are falling out of the sky, right? As women, we'd be trying to construct a shelter or canning vegetables, and the guys would be like, "Hey, can we get it on one last time?"
One last time.
One last time. I just think we're hardwired a little bit differently in these things. And I think stress has such a greater impact on our libido compared to men.
Mhm.
I'm not sure I have a single scientific study to back that up, but that's just
I went to a menopause conference years ago, and the speaker was talking about sexuality, and and he showed uh, an amplifier system or something, and it had one switch, and he said, "This is male sexuality. It's either on or it's off.
Mhm.
One switch." And then the next slide was this device that had like 50 buttons on it. He said, "This is female sexuality, and everything has to be on at the same time." So
Yeah,
it's hard. It's a hard
it is. We're
um,
definitely hardwired
situation.
differently.
And now tell me a little bit about the O shots that
Yeah,
that are
for
for sexuality for
for
women.
sure. So, platelet-rich plasma therapy, right? We draw somebody's blood. We use FDA approved vials to centrifuge and separate the plasma layer, which is rich in platelets, hence platelet-rich plasma. We isolate that away from the red blood cells, and you can inject that in any part of the body. I don't mind sharing, I've had it injected in my ankle twice, my elbow 3 times. It's great, and orthopedics uses it with pretty decent frequency. Again, I can't speak to their literature,
Okay.
but I do know that it's used for hair loss,
Uh-huh.
and has some studies behind it to show that it really does work. I have heard, I don't know exactly how, but I feel like, our retinal colleagues use it.
Mhm.
Again, you feel free to fact check me on that one.
Okay.
And then I also have heard that burn victims have been treated with PRP.
Okay.
So for us, the O shot, um, platelet-rich plasma contains growth factors. One of the most important ones is vascular endothelial growth factor, and it does exactly what it sounds like. It helps to grow blood vessels. And so if we are improving blood flow to any given area, especially the clitoris, it helps with orgasm in our situation, right? We're trying to optimize orgasm because one of the many things we hear is that maybe it's taking too long to reach orgasm. It's muted, and the clitoris does get smaller with time. And so if I have patients, many of my patients that because the O shot doesn't last forever, right? We're constantly fighting senescence, that aging process, right? So a lot of my patients that do well with the O shot in regard to clitoral response, they will come at intervals, maybe like every year, to get a repeat O shot. And the clitoris is bulkier in those women because the growth factors also include factors for collagenesis, growing collagen. So if we're improving blood flow to the clitoris, that's significant in helping with orgasmic potential. The other place we inject platelet-rich plasma is right underneath the urethra. So if the urethral opening's here, a little bit further back in the vagina, we inject it where there are glands that help make moisture with arousal. And if we're being brutally honest, that's the part that I see works the best for my patients is that, especially if I have somebody that, for whatever reason, doesn't feel comfortable using vaginal estrogen, the O shot can be very helpful for them. And because conveniently where it's located, it can help with mild stress incontinence. Now, I would never sit here and tell you that it's first line therapy for stress incontinence. That still is physical therapy. And then other things that can go along, procedurally that can help with incontinence. But I think it's a nice adjunct. Um, to those things. So the O shot, has been around for over a decade.
Okay.
And a lot of people poo-poo platelet-rich plasma, but I think the science is growing about its efficacy.
And you hear the feedback from the women who have had it.
Yeah, I do. I
Yeah.
do. We try to keep some statistics. Right now, in regard to satisfaction for vaginal moisture, we're running in the low 80% for the moisture.
Okay.
Clitoral function, more like in the 70% range. And I
Mhm.
do think too that there's a lot behind that as well.
Yeah.
Again, that's talking about your fancy machine with all the buttons and switches. You know,
Yes.
if
There's many things that go into that.
yes, yes. I mean, we're thinking about like balancing the checkbook, changing the light bulb, and that's just during sex, and that's just really not.
But I think, Kristen, what you're saying is actually giving hope. I think so many times, women and men, we think, okay, we're aging and there's really nothing we can do. Our sex life is going to
Yeah.
get less interesting, or we're going to be less interested. But it's nice to hear from you that there's vaginal estrogen, that there's possibly testosterone therapy,
Mhm.
that there is cognitive behavioral therapy,
Yes.
that there's giving yourself some grace and saying, I'm one human being, I can't
Yeah.
tackle it all,
Yeah.
that there is potentially the device that helps to relax some muscles in our vaginal vault if we're having contractions that trigger
Yeah.
pain.
Yeah.
And there's an O shot that's putting our own
Yeah.
plasma-rich platelet plasma
Platelet rich blood.
PRP
Yeah.
plasma-rich platelets back into our um
Yeah.
uh
And there is a prescription
back into
medicine.
our tissue.
Yeah, and we do have some prescriptive medications that are supposed to help with orgasm as well. They have
Yeah.
their own contraindications. Um, and I'm not sure if you realize this, but the United States has a misogyny issue right now. And so it's really prevalent in the insurance industry. And so it can be difficult to get some of these medicines that if a patient doesn't have a contraindication to use to get them paid for them. But there are some on the market. So
And
yeah.
how often do you find that Viagra helps women?
So I've only used Viagra in women as a topical compounded cream.
Okay. Mhm.
Um, and the compounding pharmacies, I think they cleverly call it the scream cream.
Yes. Yes, they do call it the screen cream.
They call it
I've
scream
seen
cream.
that.
Yeah, so that's the only way I have actually used it at this point
Okay.
for
Okay.
patient is topical application to the clitoris.
Okay.
Yeah,
Um,
and that's again not approved by the FDA at this point. Uh,
no, no.
compounding pharmacies or cash pay. Um,
Yeah.
yeah, so.
But this has been so exciting and hopefully some helpful ideas for women that are listening.
Yeah, exactly. Like we can think outside the box.
Yeah.
I think sometimes when we use these compounded medications, we do have to understand that a lot of times insurance won't cover them. But
Yeah.
in particular, like for women that have a painful vaginal opening that just estrogen hasn't helped on its own, you can get it can either be a suppository or cream that's even got gabapentin.
Yeah.
Um,
Okay.
it will have a little alprazolam in it to help with
Uh-huh.
relaxation, and baclofen is an anti-inflammatory. And if you
Okay.
want lidocaine, you can put
Oh, there's a
lidocaine in there
muscle.
too.
Okay.
Yeah, so
So it
it's
has
like
like okay, so for pain, a muscle relaxant, lidocaine to numb,
yeah,
and you're already using some estrogen. So you have
yeah,
all of those things. That's
yeah.
amazing.
So sometimes it's we can do a lot of things, and that is a great I think that's a great utilization of the compounding pharmacies is they can put stuff together for us that we wouldn't be able to do.
Perfect.
Yeah.
Perfect. Thank you so much, Kristen. And I'm hoping that um, women will get ideas from this and talk to their doctors and
Yeah.
medical providers and realize that there's solutions that can be tailored to all our needs.
Yeah, absolutely. It's definitely not a time for hopelessness. I think
Yeah.
one of the big things about menopause is it can be very freeing, I think, because you're not a
Okay.
slave to your period anymore. You're not a slave to the
Yeah.
potential of unplanned pregnancy. And if
Yeah.
we can help shepherd you through it, it can be liberating. Also in your
That's
50s,
that's a
you
great
find, yeah, I think in our 50s, we figure out how to say the word no a lot more often.
a little bit better, and
No,
that's
I
good.
don't want to do that. I'm an adult grown ass woman. I am not doing that.
Yay.
Yay.
Thank you so thank you so much, Kristen. I appreciate it.
You're welcome.
All right. You have a great rest of your evening.
Yeah, you too.